Good afternoon and welcome to the Long COVID and Post-Infectious Syndrome ECHO series, a collaborative effort between the University of Utah and the Bateman Horne Center. If you're joining us for the first time, we're thrilled to have you here. And if you're returning, welcome back. I'm Talia Raschioni, the Education and Deputy Executive Director at the Bateman Horne Center, and I'm joined by Sarah Day, ECHO Manager at the University of Utah. Before we get started, just a few quick housekeeping items. Today's session is being recorded. However, all participant details and sensitive case discussions will be removed before sharing the recording on our websites and the YouTube channels. After this session, this is probably the most important housekeeping item, Sarah will email the CME instructions and a copy of the slide deck. Please make sure that you claim that CME credit by midnight tonight using the call-in option. And it may take up to 24 hours for this to appear on your profile. We invite you to introduce yourself in the chat and engage as you feel comfortable throughout today's presentation. Our topic today centers on caring for complex multisystem patients. Jennifer Bell, nurse practitioner at Bateman Horne Center, will walk us through 3 clinical cases that reflect our team's approach to managing these complex and challenging case presentations. She'll demonstrate how to break down and organize care strategies in ways that are practical and applicable in both primary and specialty care settings. This session also serves as a preview to our clinical care guide, which we have set to release this Friday. This guide expands on each element of Jennifer's talk, offering structured, tangible assessment and management strategies, ultimately culminating the key learnings from the past 3 years of our ECHO series. So we hope that you can access that and use it in your practice. We also hope that today's session will be interactive and enriching, so please don't hesitate to use the chat box throughout Jennifer's case presentation, and our mentors and our other peers on this panel will engage. So, Jen, let's go ahead and get started.
Thank you, Talia. Okay, as Talia mentioned, this is a practical approach to complex long COVID and MECFS patients. My objectives today are to define what is a complex long COVID MECFS patient, what are the commonalities and differences among these patients, and to discuss some assessment and treatment approaches for complex long COVID patients, and to develop strategies for care for complex long COVID patients. During this lecture, I'm going to present 3 different patient cases. Each patient has given their permission to use their case, and no identifying information will be used in the presentation. So the purpose of this talk is to discuss our approach of long COVID MECFS patients in general. It is not intended to give you a step-by-step assessment or treatment protocol, but more to discuss the concepts and what to consider and anticipate with a complex patient. I'm making some assumptions here that the audience has some experience with infection-associated chronic conditions like MECFS, long COVID, and their comorbidities. But if you need more information on these conditions, their definitions, their assessments, and treatment protocols, please refer to our prior echoes where we've gone into detail about treating, assessing, and treating these comorbid conditions. And we're also going to be providing you some links during this lecture today. As Talia mentioned, this talk does dovetail with these new clinical care guidelines that are coming out this Friday. So that's very exciting for us. What makes a long COVID patient complex? What makes an MECFS patient complex? From the lens of long COVID, when a long COVID patients can present with very minimal symptoms, and sometimes they can develop very complex symptoms with multiple debilitating comorbidities. They often have severe loss of physical and cognitive function, severe pain, persistent instability of their overall condition. It can be a very, very challenging illness to live with. These are the patients I'm going to talk about today. While this lecture focuses primarily on long COVID MECFS patients whose primary viral trigger was COVID, this lecture also encompasses all complex MECFS patients regardless of the triggering mechanism. So the most important aspect of this slide is right here. Patients with multiple comorbid conditions have a tendency to be increasingly complex. They meet the MECFS criteria and have significant post-exertional malaise. They have dysautonomia, often very severe. Their mast cell activation syndrome is definitely present, and it usually is relatively severe and difficult to control and sometimes very severe. And a new comorbid condition that we for the last couple of years have been really trying to get our arms around is hypermobility, connective tissue disorders. We know that this plays a big role in our more complex patients, and we are every day learning more and more on how to assess for and manage this comorbid condition. This can include craniocervical instability, atlantoaxial instability, tethered cord, symptomatic intracranial pressure fluctuations, venous compression, and congestion syndromes. And it is this group of patients with these comorbidities that make our most complex patients at this point, from what we understand. Other aspects of complex patients usually include patients who have multiple drug sensitivities, meaning they have paradoxical reactions to medications. They have reactions that just don't make sense. You give somebody a Tylenol and they have this very unusual reaction in terms of like maybe increasing anxiety, nervous system response that makes it impossible for them to take the medication. We think this is most likely secondary to a hypersensitive nervous system that's in a fight or flight response and looks at everything as a threat. So that can be very challenging to help these patients if they have trouble initiating any medications. These patients also have a tendency to be treatment resistant. Sometimes we might make some headway on their condition, but not as far as we'd like to go or as we usually go, or we can't even figure out a way to kind of get traction on being able to make improvement in their condition. They're just not responding to the usual treatments. These patients often have repeated COVID infections. They may have a tendency towards MECFS, post-exertional malaise, orthostatic intolerance, and you can get that in your very thorough history that you'll take. You might see sort of some stepwise reduction in function that they noticed but never really paid much attention to, where they had fatigue, they never fully got over that flu, or they never fully recovered from that pregnancy, and where they might have had just sort of the stepwise slight reduction in their illness, and then they get the main triggering event, particularly COVID, and now they're much sicker. And obviously prior health conditions like diabetes, asthma, COPD, all autoimmune illnesses all have predisposing factors. This slide is from the 2020 US MECFS Clinician Coalition guidelines. It highlights how multi-system MECFS can be and outlines some of the comorbid conditions we frequently see. Many of our long COVID patients, long COVID MECFS patients and complex MECFS patients have one or more of these comorbid conditions. So in the next section, I'm going to present 3 cases. I've taken specific information from these cases to highlight what makes these patients complex and certain unique details in each case that show how diverse patients can be. So patient case number 1. This is a 35-year-old woman, and I actually should have written this a little bit differently. She actually had a tendency towards MECFS prior, but then got COVID and developed a long COVID MECFS presentation. She had a history of EBV, which led to some orthostatic intolerance issues, but it didn't impact her life significantly. In 2015, she developed a severe vestibular neuritis, which led to intermittent POTS and post-exertional malaise events. And between 2015 and 2022, she had some pretty serious episodes to where she was sick for 4 to 6 months with POTS and PEM. But then she'd recover pretty much back to baseline. In 2022, she had her first COVID infection. It was a mild to moderate infection, but it resulted in severe dysautonomia that took almost a year to recover from. And then, unfortunately, about a year later, she developed another COVID infection in September 2023. Again, it was a mild to moderate infection, but it resulted in severe dysautonomia, POTS, and disequilibrium, and ultimately with her being bedbound. Fortunately, I was able to see her about 2 months after her second infection. And at that time, I diagnosed her with MECFS that was very severe, with symptoms present 75 to 100% of the time. Her orthostatic intolerance questionnaire brought her in at 91 out of 100, with 100 being the most severe. Her nasoline test was quite abnormal. She had a low resting blood pressure, an increased heart rate of 43 BPM, and a pulse pressure that was below 25%, indicating she had a decrease in venous return to the right side of the heart, thus possibly worsening cerebral perfusion and tissue perfusion. When we do our lean test, we will do cognitive testing with the Dana Brain Vital test, and after the lean test, she was unable to complete the test. She couldn't figure out how to answer the question, so we were unable to calculate it, but her cognition was deeply affected by the nasoline test. Her mast cell screen was mild. There wasn't really much there that concerned me, and other diagnostics were essentially normal. And over the next year and a half, I intermittently monitored her for mast cell emersion of mast cell activation syndrome. And what I found, it was primarily a presentation in her post-exertional malaise, but it never fully became a constant issue. Then later on, she was evaluated by a neurosurgeon after we got some imaging to evaluate for hypermobility. And he diagnosed her with craniocervical instability, atlantoaxial instability, possible tethered cord, and possible internal right jugular vein compression. So why is this patient complex? Or why do we consider her to be complex? She probably had MECFS, met the criteria for MECFS periodically prior to getting her COVID infection. She had had repeated COVID infection with severe long COVID symptoms. She had had some medication sensitivity, which it was challenging to initiate many other medications. And I often had to start very low in the dose and go up slowly. And she has the complex triad of POTS, MCAS, and hypermobility. So the treatment of focus. As you'll see, this is repeated over a number of times in this presentation. The first thing I started with was pacing and reduction of post-exertional malaise. That is the top priority. If you don't focus on this, then all the medications you add, other interventions are not going to be as effective. So this is the most important thing, to identify that PEM is there and then help them learn how to pace and avoid PEM. Of course, I addressed her dysautonomia and orthostatic intolerance by managing her vascular volume to provide vascular volume support, vascular compression, and utilized vagal nerve stimulation techniques. As she was medication sensitive, I had a little trouble initiating medicine, so we tried to use some non-pharmacologic approaches. We also optimized her sleep. She was already on temazepam and trazodone, and so I adjusted those medications to really make sure her sleep is as sound as possible to improve deep sleep. As I mentioned before, her MCAS never really took hold. However, I was concerned that it was there, particularly because I could see it in post-exertional malaise. So I put her on a daily quercetin as a precaution, and she's done well with that. When we met with the neurosurgeon, she was doing better, and so he really didn't recommend a surgical approach. He recommended isometric neck exercises, core strengthening, and management of her dysautonomia, MCAS, and PEM. And presently, it's been a year and a half later, she's doing very well. She's back to baseline prior to her second COVID infection and is actually a little bit better. She has many more tools to manage her dysautonomia and pacing, and really understands much more about PEM avoidance. I feel the fact that I was able to get to her pretty early on and provide as aggressive interventions as possible, I think it greatly improved her chances of not becoming more severely ill. So patient case number 2 is a 19-year-old woman with long COVID MECFS. We know she had a significant COVID exposure in September 2020. She never tested positive. She never had symptoms. But what did happen to her is about 3 months later, she started to develop tachycardia, dizziness, shortness of breath, brain fog, and weakness in January 2021, when she had a highly exertional part-time job. Prior to this, she had been quite healthy. She had a little postprandial abdominal pain and some IBS symptoms. So in March 2021, when she did get her first documented COVID infection, she already had some symptoms of dysautonomia, and these symptoms worsened to the point to where she was diagnosed with POTS, and she ended up needing academic accommodation at her college. She became a patient of mine in 2022. She met the MECFS criteria with severe to very severe symptoms occurring 75 to 100% of the time. Her lean test was positive for POTS with a heart rate increase of 37 BPM, a pulse pressure of 16%, which is significantly reduced, resulting in significant symptoms of dysautonomia, to where during the lean test she experienced shortness of breath, shaking, sweating, thirst, and increased emotions, which was really, really hard for her. Every time she stood up, she would start to have all these emotions well up. Her mast cell screen was quite mild, but her GI history made me a little suspect, so we kept an eye on that. She already had joint pain. She had a family history of connective tissue disorder, and she'd seen a rheumatologist before seeing me and had been diagnosed with undifferentiated connective tissue disease. Additionally, she'd seen a cardiologist before seeing me and been started on the usual hydration, sodium, fludrocortisone, and midodrine, but hadn't responded very well to it. So she was already a little bit treatment resistant. Her mast cell over the next 3-4 months, actually it was close to 6 months, she started to develop more unusual reactions to medications, but one in particular caused some low-level angioedema, which was obviously very concerning. I did a little more evaluation and found she had a low C1 esterase, and at that point I thought allergy and immunology should be involved. And so I referred her to the allergist. The allergist diagnosed her with mast cell activation syndrome and treated her aggressively with that. And also during that time, I had been able to increase her hydration and really made her sodium supplementation more aggressive using electrolytes as opposed to just dietary sodium. And that seemed to make the difference in helping her tolerate the fludrocortisone and midodrine better. So we had her dysautonomia pretty well controlled. Her mast cell was being aggressively treated, but she still wasn't making that much headway. She had stabilized somewhat, but she still was much sicker than I would have expected her to be, which then brought up the thought that maybe there's some hypermobility involved, particularly with the history of connective tissue disorder in her family and possibly herself. So we had her see physical therapy, who identified her as being hypermobile, and then she also had some genetic testing done as well. So we know that that is playing a role in her illness. Additionally, she was diagnosed with celiac compression or median arterial ligament syndrome, and is actually going to be getting surgery in the next couple of weeks to release that. And we're curious to see how that's going to affect her overall. So why is this patient considered complex? Well, she may have had a little MCAS before COVID, and I'm maybe stretching a little bit, but her GI symptoms make me suspect that there might have been something a little bit brewing there. She has undifferentiated connective tissue disorder and a family history of connective tissue disorder. She's had repeated COVID infections. I know she's had at least one more, so she's had, I think, a total of 3. Medication sensitivity, treatment resistance, and she's got the triad of POTS, MCAS, and hypermobility EDS. So the treatment focus, again, top priority was pacing and reduction of post-exertional malaise. So we spent a lot of time talking about that. Then we looked at her dysautonomia. I worked on supporting her vascular volume and providing vascular support, aggressive oral hydration and sodium supplementation. IVs were not that beneficial and have never been that beneficial for her, which has been surprising for me. And now she's doing pretty well with vascular compression, fludrocortisone, and midodrine. We've also managed her heart rate with beta blockers, which has also helped control her sympathetic overdrive. And as I said before, she's had some mild to moderate improvement in upright tolerance, less emotional, less cognitive impairment, heart rate variability and resting heart rate have been improved, but she's still pretty significantly impaired physically and some cognitive impairment as well. Allergy has done a great job at keeping a very aggressive MCAS regimen going with her. And she's working with a physical therapist who's really working with her with isometric neck exercises, recumbent core strengthening, joint strengthening, and working on post-exertion recovery, and it's made a huge difference. And so along with her aggressive management of dysautonomia, mast cell, and the PT, her hypermobility is stabilizing. And we're going to see what happens with the celiac artery compression surgery. So patient case number 3. This is a 31-year-old woman with long COVID MECFS. Her initial COVID infection was November 2020. She came to see me in December 2021 with an already existing diagnosis of POTS, and she was 6 months pregnant. She has a past medical history of endometriosis, some iron deficiency anemia, and migraines and menorrhagia from the endometriosis. She had already been evaluated by cardiology, neurology, and GI. Was being treated aggressively for POTS with water supplementation and dietary sodium, PRN, propranolol, and compression. When I met her, she met the criteria for MECFS with moderate to severe symptoms 50 to 75% of the time, and her OI was about 75 to 100% of the time. So that was the primary issue. Her lean test was positive for orthostatic intolerance, but not POTS, and she still had a drop of her pulse pressure below 25%. And her symptoms were venous pooling, head pressure, headaches, shortness of breath, and increased restlessness. She'd had a pretty extensive laboratory evaluation before I met with her. I did some additional viral testing on her to see if there are any other viruses other than EBV present. And she came up only positive for EBV in the past. I pushed her sodium supplementation a little bit more utilizing electrolyte powders, which did make a difference. Educated her on pacing and PEM, and she was doing pretty well. And I know the expanded vascular volume of her pregnancy was definitely helping. We knew it would change when she had her baby. So how did she do postpartum? Well, she did pretty well for the first couple of months. And then she started to experience bone-crushing fatigue, dysautonomia, widespread pain, headaches, different from her prior migraines. These were more pressure headaches. The repeat nasoline test was not as abnormal as I anticipated. She had a little bit of an increase in her diastolic blood pressure, but other than that, it wasn't that abnormal. She was nursing, so we had limitations on what medications we could employ, so we really focused on oral hydration, sodium, and compression. And then her mast cell screen came back more positive with an elevated histamine level. I did suggest trying some liquid cromolyn, but she was uncomfortable, and I respected that. So we focused on low inflammatory histamine diets and avoiding triggers. And then I didn't see her for 14 months. I think she was busy being a mom to two little kids. So I did see her back though. She came back to me about 14 months later in November 2023 with worsening and persistent post-exertional malaise, brain fog, dysautonomia, labile blood pressure and heart rate, MCAS flares, sleep disturbances, widespread pain, increased menorrhagia, and worsening iron deficiency anemia. Her cardiologist was managing the iron deficiency anemia. She had 3 iron infusions scheduled, and over the next month, she had those done. I kept hoping the infusions would miraculously improve her condition, and it helped somewhat, but it didn't help anywhere near as much as I'd hoped, and she had an MCAS reaction to one of her infusions. She had already self-referred to an allergist and immunologist who she had seen the week prior. She had also self-referred to a geneticist for hypermobile EDS evaluation. And this evaluation revealed possible classical EDS. He questioned hypermobility, but on exam, I felt she definitely had hypermobile presentation, and she hasn't had the genetic testing done. She also had a repeat COVID infection about 6 months later, which definitely worsened some of her symptoms. So I consider her complex partly because of her past medical history of endometriosis and connective tissue disorder. Endometriosis is one of the comorbid conditions we see with ME/CFS patients. She's had repeated COVID infections, and she has the quadrat of ME/CFS, POTS, MCAS, and hypermobility connective tissue disorder. So I'm repeating myself somewhat to sort of drive home some of the similarities that these patients have. So what was our treatment focus? Again, it was pacing and PEM avoidance. That was a top priority. I addressed her dysautonomia with oral hydration and sodium. She was still nursing. We needed to really make sure we did that. And we also had some limitations on medications that she was comfortable using. So we focused primarily on non-pharmacological approaches, vascular volume support, oral water and sodium, vasoconstriction with compression. We also utilized propranolol for heart rate control and really focused on trying to improve her sleep with sleep hygiene, sleep relaxation techniques, vagal stimulation techniques to really improve that deep sleep. And that definitely did help. Her allergist did diagnose her with MCAS and started her on an MCAS regimen, which definitely helped. She definitely had an improvement in her overall symptoms when she got going on that regimen. Over the next year, she had a 1.5-year-old and a 5-year-old at home. She was homeschooling her 5-year-old. She was trying to be the mom she always dreamed that she would be. And she was just basically in a push-crash cycle. Every time I met with her, which was every 2 or 3 months, she was doing pretty well, but kind of just hanging on. And she was trying to keep all the balls in there and finding it very difficult. Unfortunately, end of October, early November, she had a really severe crash. She was nearly bedbound. When she reached out to me about 2 weeks later, she said, I thought this was all really mast cell related. I now understand how important it is for me to control, to learn how to pace, learn about post-exertional malaise, how do I avoid PEM, and how do I change my life to be able to live with the reality of post-exertional malaise. We spent a lot of time talking about that. But at the same time, she was really quite severely ill, and I needed to try to help get her nervous system under control. So for the first month, we employed IV fluids 3 times a week. I worked on controlling her dysautonomia with benzodiazepines, beta blockers, dextromethorphan, and any vagal nerve stimulation techniques she could manage doing. We did aggressive rest and pacing, and even though she was almost bedbound, there were still things that we could do to reduce the amount of stimulation that she was having. Fortunately, her mother came and stayed with them, so she didn't have to focus on taking care of her children, and she could focus on herself. It took about a month to really get her stabilized. And then over the last few months, we've really gained some control and function. She's up making her children lunch and dinner, and she's doing much better. I've been so impressed. She's really embraced the concept of pacing and PEM avoidance and is trying to move forward in her life with sort of this new reality of how she's going to need to take care of herself. So I'm hopeful that she gains more function and stability, and time will tell on that. So I'm just going to pull back a little bit and discuss some general strategy when caring for these complex patients. First of all, you really have to try to remove the idea that this is linear or algorithmic. You have to stay flexible and be willing to adjust your approach. This illness waxes and wanes and evolves over time. There are no 2 patients who present and respond to treatment the same way. A strategic approach, understanding how each comorbid condition interacts with the other, how this illness can evolve, and the heterogeneous response by patients will help you navigate this complex presentation. It's also really important to be a partner, collaborate with your patient. Your patients know a lot about their illness. They can teach you a lot. They have had to advocate for themselves that this illness is not well understood in our general medical community. Your patients have done a lot of research, attended educational forums, networked with other patients, and have a really good understanding of what's going on with them, ideas that might help them feel better, but they need your help. So really listen to your patients and engage with them. This is an absolute partnership. The other thing I think it's important to do, the clinician needs to do is set expectations, not only for the patient, but for yourself as well. I've had many patients report to me that they've been told nothing can be done for their long COVID. This is all in news articles, it's in interviews. It drives me nuts because there is something that can be done. We may not be able to cure this illness, but there are certainly things that we can do to help stabilize the patient, improve their function, possibly enabling them to be able to continue to work and engage with their family and community, but most importantly, give them some hope, because there is hope. There are things that we can do to really improve their situation. So it's important to have realistic goals for the patient. It's also very important for you as the clinician to understand that there are going to be setbacks. This is not an easy process. Even with less complex patients, you will have 2 steps forward, 1 step back. It's going to change. Stay open to the dynamic aspect of this illness. And then medication strategies, and this can also go beyond medications. Dr. Zeest Khan wrote our first chapter of the clinical guidelines, and she used a great phrase, trial and pivot versus trial and error. I really like that because we have to try a lot of things, and sometimes they don't work, and we have to try something else, but it doesn't mean it was wrong or it failed. It just means that maybe the patient wasn't ready for that medication at that time. Maybe we need to adjust the dosage. Maybe it's something that we can try again later. So it's really important to start one medication at a time, one intervention at a time, so you know what's causing what. Start very low dose and move up slowly on the dose. Sometimes we have to start on doses that are ridiculously low. You just think this is not doing anything. But we need to tell the immune system or the nervous system that what you are providing them in the medication is not a threat to the body. So it's really about helping the nervous system relax and understand that this medication is not going to hurt it. You want to consider compound formulations, remove a lot of additives or excipients that can sometimes cause reactions, and enables you to have really low doses. And if something doesn't work, you can try it again later. It's also really important that you are willing to try interventions, but make sure you stay within your comfort zone. We talked about this in our clinician meeting this morning. While there are no FDA-approved treatments for long COVID and ME/CFS, there are FDA-approved treatments for many of the comorbidities. And there's a lot of research and case studies to support non-FDA-approved approaches. You need to do a risk-benefit analysis of whatever intervention you're looking at or your patient's talking with you about. Attend CMEs like this one to expand your knowledge and comfort zone. Stay current on emerging research, utilizing ME/CFS forums, both lived experience and clinician-driven. This will help expand what you can use to help these patients. You just need to come to grips with the fact that this patient's going to need to be seen frequently, every 2 to 4 weeks. The every 3-month visit you're not going to make any traction with these patients, especially in the beginning. You need to see them frequently, follow up with how they're doing with interventions that you're prescribing or recommending. Are they responding? Do you need to adjust the dose? So you need to follow up with them regularly. Sometimes the follow-up might need to be a longer, more comprehensive visit, and other times it can be a targeted visit. If you can, utilize telehealth for as many visits as you can. Just the act of leaving their home can be PEM inducing. And if you can see them for some of their visits through telehealth, you're actually going to be helping them a lot. Empower your patient with knowledge, resources, and tools, and we have a ton of them on our website. And make sure you assess needs for academic and work accommodations and disability needs. Many of these patients will end up needing to have some kind of accommodations, and they may need to apply for some sort of disability. So when you're charting, chart with this in mind. You want to make sure you're accurately representing the patient in the chart, that you're accurately representing what their disabilities are and what their capabilities are. So be careful of comments like healthy appearing. I've had that come back at me a couple times, where healthy appearing is sometimes interpreted as they're fine, they're healthy, they look healthy. I don't use that term anymore. Describe what's going on with the patient. Describe how their cognition is faltering as the visit goes on. Describe what you're seeing. So make sure that your charting is supportive of help. And then you want to assess needs for and access to social services, mental health services, and community support. I'm not going to go through this, I promise. You've seen this many times. So with all of that, I'm going to reinforce, where do you start? You start by listening to your patient's story and determining whether they might meet the criteria for ME/CFS, and do they have post-exertional malaise. You want to evaluate what kind of function did they have prior to getting sick and where they are now, and it will provide you an incredible insight on how much this illness has impacted them. If they have PEM, they meet the criteria for ME/CFS, then you know that you're going to have to work with this patient with that in mind, and helping them learn to pace, avoid post-exertional malaise, and addressing the comorbid conditions that go with that. If they have severe PEM and it's very frequent, it increases my suspicion they may be a more complex patient, but that's not always the case. And it's really important to remember from previous lectures that the more patients experience post-exertional malaise, the longer and more severe the PEM episodes, the more likely they will have permanent loss of function. So this is why it's so important to identify this. You want to assess and reassess for PEM symptoms throughout the time you're working with them. PEM can actually develop over time, so pay attention to that. Questionnaires can also be very helpful. Good day, bad day questionnaires is one that we use quite a bit in our clinic, and really provides some great understanding of function and how interventions are helping or not helping. The DePaul symptom questionnaire and the SF-36 functional assessment scale can be very helpful for disability. After you've determined whether they have ME/CFS and PEM level, then you're going to want to go to dysautonomia. This is the low-hanging fruit. So for every patient, you're going to assess for this, even if they don't seem to necessarily have the symptoms for it. It's interesting how sometimes patients don't perceive that their heart rates are going up. So listen for a history that suggests dysautonomia and orthostatic intolerance. Do the 10-minute lean test in all the patients. Do an orthostatic intolerance questionnaire. If you can, do a Compass 31 questionnaire, which looks at other dysautonomia symptoms. Assess cognitive function. And you can, if the patient chooses to, use devices like the Oura Ring, Fitbit, Apple Watches to assess for heart rate variability, resting heart rate trends, sleep trends. This can all make a difference in getting to understand their illness and how different interventions affect them. You're going to treat with supporting their vascular volume, vascular compression, managing heart rate and blood pressure, improving cardiac output and cerebral perfusion, really focusing on their sleep. Most of our patients' sleep disorders are more secondary to autonomic dysfunction, neuroinflammation, pain, and mast cell, as opposed to just sleep apnea. If you treat the autonomic dysfunction, neuroinflammation, pain, and mast cell, you may get significant improvement in their sleep. Vagal nerve stimulation is one technique that I really think is important for patients to learn how to do. That involves non-pharmacologic approaches such as meditation, resonant breathing, neuroplasticity programs that can all help calm the nervous system down. The vagal nerve stimulation techniques really help to activate the vagus nerve, which in turn can counteract that fight or flight response driven by the sympathetic nervous system. So it can have a big impact on many patients. Once you've determined whether it's ME/CFS with post-exertional malaise, dysautonomia, mast cell activation syndrome is also critically important to assess for. You're going to want to listen to their symptoms, screen patients for mast cell. Laboratory evaluation can support your diagnosis, but it isn't always positive. Have a low threshold of suspicion for MCAS and reassess for it frequently if you're not seeing it at first. It can emerge, especially if they've had a crash. And listen for MCAS symptoms as part of their post-exertional malaise. Educate patients to avoid triggers, try empiric therapy, start one therapy at a time, consider compounded medications as much as possible, establish strategies for MCAS flares, and involve a trusted allergist or immunologist if needed. Pain. I want to read this statement here because I think it's a really important statement to understand where pain can come from in these patients. Pain and infection-associated chronic conditions such as ME/CFS, long COVID, fibromyalgia, and hypermobility syndromes arise from a complex interplay of neuroinflammation, autonomic dysfunction, impaired pain modulation, and musculoskeletal instability. So you can see that there are a number of different causes for pain in these patients other than inflammation, let's say, or joint inflammation. The pain of fibromyalgia is usually widespread body pain. It's diffuse, it moves around, it's neither joint or muscular. It will wax and wane with post-exertional malaise. It often has a nerve pain, burning, tingling, numbness as well, which suggests also small fiber polyneuropathy. Joint pain, subluxations, dislocations, I start thinking maybe hypermobility is more at play here. If I have somebody who has pressure type headaches that are treatment resistant, intermittent, come and go, worsened with fatigue, I'm starting to think that hypermobility, venous congestion syndromes. Or complex patients, if headaches are part of their presentation, these headaches can be brutal and very, very difficult to treat. Assess using fibromyalgia questionnaires, small fiber neuropathy, primarily a clinical diagnosis, but you can get a skin biopsy or QSART testing at a dysautonomia lab. You want to assess for hypermobility, connective tissue disorder, and any other imaging and diagnostics that you feel are appropriate for the pain presentation. And you're going to treat, thinking back to that statement I read earlier, you're going to think about what can drive pain in these patients. So avoid PEM, it's key. Pacing, PEM avoidance can greatly reduce pain. Treating their autonomic dysfunction, fluids, compression, dysautonomia treatments. Sometimes I have patients coming in who say fatigue and pain are their primary issue. And when I get the pacing and the dysautonomia and the fluid supplementation going, a lot of their pain recedes. Manage their mast cell. Mast cell triggered pain is challenging and something I think we're still trying to understand, but many patients have improvement in pain, particularly headache pain with mast cell management. And optimize their sleep. Sleep is critical for pain management. The more they can get into a deep sleep, the more their body can self-heal, which helps reduce dysautonomia. It sort of helps everything. So using low-dose tricyclics, melatonin, dysautonomia treatments, again, can be very helpful for sleep. Utilizing central sensitization medications such as low-dose naltrexone, tricyclics, SNRIs, gabapentin, pregabalin are all incredibly helpful for pain and often first-line therapy for us as well. And utilizing standard pain medications, whether they're OTC or prescribed, and refer to pain management as appropriate. Now I have one slide on this, which doesn't even begin to scratch the surface, but it's just a couple little things I wanted to bring up. So hypermobility, connective tissue disorder. This is a huge topic, and as I said earlier, something we are still learning an enormous amount on. But hypermobility can present in musculoskeletal manifestations of joint pain, subluxation, locations, overuse injuries, autonomic dysfunction and dysautonomia, mast cell, and again, those headaches, those base of skull pressure headaches, positional headaches, worse with PEM headaches, unresponsive to medications. I'm thinking hypermobility, connective tissue disorder. You can assess using a number of different assessment tools, the Bateman score for hypermobility, Brighton criteria used in diagnosis of hypermobile EDS, 5-point questionnaire for joint hypermobility. Genetic testing can help to identify connective tissue disorder, but remember there are no genetic markers for hypermobile EDS, but genetic testing will evaluate for other EDS variants. And then there's brain, spinal, and venous imaging as indicated. So I sound like a broken record, but you're going to go back to treatment. You're going to do aggressive management of their post-exertional malaise, dysautonomia, and MCAS. That's number one. Pain management. Have PT work with them. A physical therapist who's knowledgeable about hypermobility is so valuable in this. It has made a huge difference in how we manage our patients. Having a PT involved aids in diagnosis and management. And if you need to, referring to orthopedics, neurology, vascular, or neurosurgery is indicated. I wanted to talk very briefly about referrals. These patients are overwhelming and can be very hard, but you don't have to do it all alone. If you have some trusted referral sources, specialists that you feel you can have a collaborative relationship with, help them learn about your patients and they can help you learn about your patients as well. So it's finding the right referral sources and specialists that you trust. But it's really important to be very clear as to why you're referring these patients. I've referred patients, and as soon as they see the word long COVID or ME/CFS, they write back and say, we don't manage these patients. I've gotten that a number of times. So you need to be very specific about what you're asking for. You need to ask for a specific evaluation for a specific issue, asking them to rule out possible concerns, asking them for specific testing or treatments. So be clear on what you want from that specialist. The most common referrals we make are physical therapy, and I've already sort of sung the praises of what physical therapists can do for us. But they need to be physical therapists who have an understanding about post-exertional malaise, or they can do more harm than good. Reconditioning with PEM in mind is one thing that I've had a number of physical therapists work with me on, and it's made a difference. They've been able to help our patients get stronger while not inducing PEM. Hypermobility, evaluation and management, provide strategies for pacing and exertional recovery. And pelvic floor physical therapists can really help with core strengthening, particularly if there are some urogynecological or tethered cord issues. Occupational therapy can be immensely helpful, particularly with our severely ill patients who are primarily house or bedbound. They can really help them in understanding how to pace within their home and life. Speech therapy. Communication specialists can diagnose and treat disorders of communication and cognition, as well as voice, speech, and swallow dysfunction. They can help with cognitive processing and memory. Of course, allergy and immunology is a really important one as long as you feel you have a good collaborative relationship with them. Neurocognitive testing or neurocognitive specialists, particularly for cognitive testing, I primarily would engage them for disability, but they can also sometimes help with cognitive processing and memory. I've also used neurologists, ones that I have found I can collaborate with. They've been very helpful in assessing for intracranial pressure headaches, head and neck venous congestion syndromes, and headache management, and also evaluating for other neurologic findings. Pain specialists for pain management interventions and stellate ganglion blocks. Behavioral and mental health specialists can be very helpful with processing medical and grief trauma, along with challenges associated with chronic illness and chronic pain. Cardiology, I have had them help me with more advanced workup and then certain prescriptions. And then, of course, there are your other specialists as needed. So my final slide here is to talk about they're same but different. So in their similarities of the patients that I presented today, each patient had a different past medical history, but they had potentially predisposing factors that may have influenced their developing long COVID. These patients also all had ME/CFS, dysautonomia, mast cell, and hypermobility to varying degrees of severity. And each patient responded to varying degrees of benefit from the same approach management. The differences, though, I would say in patient number one, I really think that her early treatment The fact that she could get to me pretty early on made a difference in her not developing more severe illness, which highlights the importance of increased access to care for these patients. The quicker they can see a provider or clinician who understands the potential of this illness, hopefully they will get interventions that will limit the severity of their illness. Patient number 2, her response to treatment has not been as significant as I'd hoped, despite a lot of efforts by myself and other specialists. She is stabilized, she's improved in many areas, but she's still not as physically and cognitively functional as I would like her to be. We are not out of ideas, we're waiting on surgery. There's some other interventions I'm looking at trying with her to see if we can get her function better. And finally, patient number 3, I think the primary aspect of this case, which is important, is the importance of pacing and PEM avoidance. People living with this illness have to embrace the concept of pacing and PEM avoidance as the primary intervention. Medications, fluids, diets can all help, but if pacing is not done, then their chance of declining is definitely high. As clinicians, we also have to embrace pacing and PEM avoidance as the primary intervention. We have to believe it ourselves and then educate our patients on pacing and PEM. This takes time, repeated discussions, collaborating with our patients to help them strategize on how to live with this illness. This is a very hard concept to really own and implement. Our culture does not support gentle self-care, which is what you need to do with pacing. It supports getting out there and exercising a lot and pushing yourself to the max. It does not support what needs to happen with pacing. So our patients really need our support and they need our advocacy. And that's all I have. Thank you very much.
Jen, great presentation. You really tied together kind of everything that we've covered in our Echo series over the last 3 years and made it very tangible and applicable. We've had quite a bit of conversation in the chat box here, covered things from vagus nerve stimulation to genetic testing for HEDS. We've also talked a little bit about identifying mast cell related pain. I want to open the forum up to our mentors and any other comments from those on the call today related to this presentation, or if you want to add anything to the discussion around your approach to care. Dr. Bateman.
I hope Jen doesn't mind me saying this, but this kind of a presentation can seem so overwhelming, but I want to tell you, we hired Jennifer Bell in 2021 as an experienced nurse. As an experienced yet nurse practitioner, but she'd never assessed or seen a patient with MECFS or long COVID, especially long COVID. And we put her in charge of seeing our long COVID patients. So she had an amazing opportunity to learn on the road. But I want you to say, please don't be intimidated by the patients because there's no one to take care of them but us. And we need to embrace them and caretake them and partner with them and with the informed specialists as the knowledge progresses. And there are many ways to support them without going too far afield from what we practice in medicine.
Great points, Dr. Bateman. Dr. Brown?
Yeah, great presentation. And I think it highlights a lot of the challenges as you get somebody into your office and it's like they have all the things and you're like, okay, how do we prioritize and understanding how all these things relate to each other and then continue to irritate each other. And I think it's hard to wrap your brain around some of it sometimes too. But I think also having the openness to say, okay, this didn't work, but I think one of the challenges is that, patients come in and they want you to be the expert and you want them to fix you, and I think resetting those expectations can be challenging at times, but I did want to highlight, I put it in the chat and we'll send out some more information as well, but, highlighting, as you did, Jen, our great PT, OT, and speech therapists who are a key part of our team. And, when we had presentations from Mayo and I've gone to presentations from the VA and UCSD, their clinics, you know, are very heavy into the support for PTOT and speech therapy, but we have also found that if we don't refer to our people, that, you know, we get a lot of we don't do this, or, you know, we don't have any education in this sort of thing. And that was one of the voids that we found. So with some of our state money, we're in the process of putting to get this together. But September 25th from noon to 4 Mountain Time, we'll be doing an online and in-person CME event for those therapists, and other therapists or other providers are welcome to attend too, but it's primarily going to be targeted towards those 3 specialties. And also CME and lunch will be available, which is also very important for getting people to come in person or online. But yeah, just let us know. We'll send out more information about this, but just trying to support those providers and gaining education and experience about how to help these patients. And we're really lucky to have our team. So thanks, guys.
I love this group because, well, one, we've been together now for 3 years working on this same mission to educate, but through it, we all have learned from each other. And it goes to show just how critical that is in that interdisciplinary approach to care. And I think, Jen, you captured that really beautifully in your lecture today. So thank you. And thank you all for being here. Please take good care of yourselves.